Hello, everyone. My name is Teresa Boitano, and I'm one of the gynecologic oncologists at the University of Alabama at Birmingham. Treat several different types of cancer, including uterine, ovarian, cervical, vulvar, and other types of female GYN cancers. And today I would like to be talking to you guys a little bit more about cervical cancer and Operation Wipeout. I have no disclosures, and so I'm not getting paid to do this and have no funding that would be in conflict with any of the things I'll be talking about today. So these are going to be our objectives. We're going to be learning more about what HPV is and cervical cancer. What's the latest info on cervical cancer screening? How do we increase HPV vaccination? And how can we eliminate HPV-related diseases? So cervical cancer is the third most common gynecologic cancer in the United States. Globally, it's a much more common cancer, but in the United States, it is slightly lower. There are about 14,000 new cases every year with about 4,300 deaths. And like I said, this is the fourth most common cancer overall in women globally. The average age of diagnosis is 50 years old. However, we do see women much younger than this being diagnosed, as well as much older as well. And so it's a wide range of women who are diagnosed. As far as estimates of incidence and mortality for cervical cancer, they vary depending on race and ethnicity. And so the highest incidence is actually in Hispanic or Latino women, but the highest mortality or death rate is in Black women in the United States. So what is HPV? HPV stands for human papillomavirus. There are more than 100 different types of this type virus that can affect the different tissues of the genitals, but also those of the head, neck, and throat. And this is a pretty common virus that is spread sexually or by mucous membrane contact. And around 80 to 90% of people will be infected at some point in their lifetime. How does HPV cause cancer? So, like I said before, it is a sexually transmitted virus. There are 15 different strains that have been associated with cancer. The two most common that we frequently hear about are 16 and 18, so HPV 16 and 18, and these account for about 70% of all cervical cancers that we see. And then there are other high risk types, 31, 33, 45, et cetera, that account for about 20% of different cervical cancers. However, there's about 46 thousand HPV associated cancers in the United States each year. So this also does affect men and through both things like penile cancer and then head, neck, and throat cancers. So cervical precancer, so before we get cervical cancer, there's something called cervical dysplasia. This is a range, can be from low grade to high grade, but over time, usually low grade turns into high grade and then eventually can turn into cancer if it's left untreated. Most with low grade, a lot of times we will monitor it very closely to see if it can heal on its own and the body's immune system can get rid of the virus. But with higher grade, we know that it needs treatment to try and prevent progression to cervical cancer. So on this diagram on the bottom, you can kind of see when we think looking at the cervix, there's normal tissue and then all the way to where you have cancer. So you have invasion of these abnormal cells into normal tissue. So how do we evaluate this? So in general, we can look screening through pap tests. And so if they're abnormal, we then need to actually get a biopsy of the abnormal tissue to figure out exactly what's going on. So this is done through something called colposcopy. I always tell women it's kind of like using a large microscope to look at the cervix. So we look at the cervix and see kind of what the abnormal areas are and then take a biopsy of that in order to figure out, is this a precancer, is this cancer, and then how can we treat that? Once those results come back, if it is a precancer and a high grade one, then we do something called a LEEP, or it's a loop electrosurgical excision procedure to try and remove all of the abnormal cells. So the goal at this point is that the body has not cleared these high grade cells, and so we want to remove them. This is frequently an office procedure. It can also be done in the operating room, but the whole goal is to try and prevent these abnormal cells so that we can prevent cervical cancer from occurring. So next, let's talk a little bit about how we can increase HPV vaccination. This is a completely preventable disease. And so, yes, we've got great screening with pap tests, and then we've got good treatment options, but how can we even prevent this from occurring? So the HPV vaccine does not contain actual virus. So that's really important to remember. It does not actually contain a dead virus. It actually uses something called virus-like particles. So it mimics what a virus would be like, but it's not the actual virus itself. It overall has a very low rate of adverse events at 0.04%. And this isn't, looking at just a couple hundred subjects. This is looking at hundreds of thousands of patients who have been vaccinated with overall very low side effects. So considered a safe vaccine in general. There are three vaccines that we think about. The first one is the bivalent vaccine, which is Cervarix. This was what most people would get 10 plus years ago. More recently, we know about the Gardasil, which at first was covered four of the different strains and now covers nine. So Gardasil 9 in general is what most women are getting at this point in time, women and men. And this covers 6 and 11, which are known to cause genital warts, and then covers 16, 18, and the rest of the other high risk strains that we know are associated with cancer. The recommendations for the vaccination have changed in the last several years. So initially, we recommended it up to age 26, and now that's changed to up to age 45. So we do recommend it for all children starting at age 11 to 12. They can get vaccinated as early as 9. And the goal is obviously to try and get vaccinated before they ever have exposure to HPV so that their body can build up an immune system to it. And so it's 2 doses prior to the age of 16 or sorry, 2 doses would, if you can get them for the age of 16, and then once they get up to 15, and then once they get up to age 26, 16 and 26, it's 3 doses. And then above that, you'll see kind of in this table that individuals who are 27 to 45, it's shared clinical decision making. And really what that means is if you have someone who, is going to potentially be exposed to it, so whether they're a healthcare provider and doing procedures where they may get aerosolized, or if they have potentially new sexual partners or those types of things, then we would recommend vaccination for those individuals. It doesn't matter if they've had an abnormal pap test before. We still would recommend that they get vaccinated. So, like we said before, this does protect against most types of HPV. It protects against 90% that cause cervical cancer, 90% that cause anal cancer, genital warts, and then also covers most of cancer that we think of from a head, neck, and throat standpoint that's caused by HPV. So why do we even care about vaccination? Does it actually work? Do we have data? The answer is yes. So we know that there have been several large publications now looking, like I said, hundreds of thousands of women. And this specific study looked at over 450,000 women with about 40,000 of those women who were vaccinated around the ages of 12 and 13, and then about 124 received those vaccines after. However, in the women who received the vaccine before they turned 14, there were no cases of cervical cancer found in any of these women. And so if we can catch women before they're ever exposed to it, we know that it works and it can prevent cancer. Again, this is kind of just highlighting the point that we know that earlier vaccination is better. However, if someone did not get the vaccine and they're, potentially at risk, that is definitely someone that we still would want to vaccinate. So kind of the main takeaway points here is that the HPV vaccine is safe. It has been used in, like I said, hundreds of thousands of individuals with very low side effect rates, and is as safe as any other vaccine that we use, and safer. And we have more data than some vaccines in general. And we don't have any data that shows that it causes any sort of mental changes, coagulation issues, blood clots, those types of things. And we know that it doesn't increase the risk of younger individuals becoming sexually active. And so that's why we do recommend it at a young age in order to do it before they ever are exposed to HPV. And so it's really important to make sure that we reassure patients, that it is safe and worth using. So we looked at, why are parents not wanting to vaccinate their children with this? And so a lot of individuals, they have a lack of knowledge. They're worried about the side effects. But a lot of patients or parents also noted that they actually never had it recommended to them. And so we know that this is something that's really important for a physician or any healthcare provider to talk to their patients about, either the patient needs to get vaccinated or their children need to get vaccinated, and recommending that it is safe, it is important, and it can prevent many different types of cancer. So overall, have a lower vaccination rate in Alabama compared to other states. And so that means that we need to do a better job of educating our patients, of educating our family members, of educating our communities as to the importance of this vaccine and how it can prevent HPV related diseases. And I think that if we do a better job educating, especially kind of getting out in the community and raising awareness about it, we will be able to get more kids and individuals vaccinated. And then just once again, I think a lot of times as healthcare providers, we don't always think about how important it is for our voice. And the study demonstrated that patients and parents really did want to hear from the provider that it was safe and recommended. The next thing is that currently the dosing schedule, if you're less than 15, is 2 doses, and then above 15 is 3 doses. However, the WHO is now demonstrating that, or potentially recommending that the single dose may be effective. And so it used to be we would worry, well, like, we don't want to start someone on the vaccine series if we don't think they're going to finish it. At this point in time, people kind of recommend get them at least started on the vaccine series, and if they finish it, great. But if they don't, there's definitely still some benefit, and eventually we may see that we completely transition to or that single dose is one of the recommendations. So finally, HPV is a common virus. It's spread by skin-to-skin contact, and this can lead over time to development of 6 different types of cancer, both in men and women. And so it's really important to encourage vaccination for both groups of people. There's currently no cure for HPV. However, people are working on vaccines to try and have that option, but those are still in the works. And so really the best way for treatment is prevention. And we know that this vaccine series works, as demonstrated by studies looking at over 100,000 women. And then really using herd immunity, meaning both men, women as a group are vaccinated, we really could eliminate HPV and HPV related cancers one day. So next, how can we eliminate HPV related disease? So it's really important that we give an effective recommendation for individuals to receive the HPV vaccine. So, not just saying, hey, this is a vaccine you need, but really taking 30 seconds to say, this is a vaccine. If you get it, or if your child gets it, it helps them build up an immunity to HPV. These are the types of cancer it can cause. And this is how you can prevent it from occurring, and then kind of giving them the data that we know that if they get vaccinated at an early age, one, it doesn't increase their, desire to go be sexually active, but it does prevent them from potential cancers in the future. So how can you do this in your own practice? So one, just educating your entire staff, those you work around, on the importance of HPV vaccination. If it's something that you want to be able to provide for your patients, if you know the billing codes and stock the vaccine, you have it as an option for your patients, and then really advertise about it and have posters up and flyers ready. So then patients may ask you about it, and then you can increase the uptake. So it's really important to identify what patients would be, potentially needing this. So make sure that you include their HPV vaccination status in your history or intake form, so that if it's someone that you should maybe address getting the vaccinated with it, or if they've already had it, then you don't have to spend that extra time kind of considering that. And then also just make sure we want to talk about series completion, not, just initiation. Although at some point in time, like I said, we may switch over to more of a one vaccine protocol. And then just as a reminder, let's say someone had a vaccine 10 years ago, but then, once didn't finish it, you do not have to restart the vaccine series. You can start off from where they finished. So if they've just got one vaccine previously, then you would give them the second and third. Um, this is just a really good resource about some different action guides that you can use depending on what situation you're in. So it's called hpvroundtable.org. And they have a bunch of different, recommendations for, depending on where you work, whether it's, in dental, if you're in the health system, or if you're in an office practice, kind of what the best way is to kind of educate and raise awareness about this. So a lot of these talk about obvious, things that we can do as far as giving presentations, trying to educate individuals about this. On social media, we see a lot of misinformation in this day and age. And so using, reputable sources to then go to your social media and kind of present actually medical factual data is a huge thing and could be really important. Other things that may not be so obvious is really trying to encourage policy change around vaccination. Every state kind of has a different take on this. And so we really want to, try and be able to advocate for individuals to be able to get the vaccine without having to have a prescription, to make sure that, it's accessible to kids in schools and those types of things. Some of the work that's being done in Alabama, we have the Alabama Adolescent Immunization Task Force. This helps with provider education. We have public awareness campaigns. So sometimes you'll see billboards and social media plugs about this. And then finally, really working on policy change. And so having insurance coverage for vaccination for older adults, and then also having a vaccine registry. So, we know that the burden of HPV related diseases is going to continue to increase despite the vaccine. So really, if we can improve our vaccination rates, we can help decrease this burden in both men and women. And so, really using your voice, whether it's in practice in the healthcare system or out of the healthcare system, and educating those around you and your community is really important. So finally, let's update a little bit about cervical cancer screening and some of the newer changes over the last several years. So we're going to go through a case report here. So this is a 36-year-old. She's presenting for her annual GYN exam. She has no complaints currently. She's had PAP tests previously that had negative cytology, but were HPV positive. And then she has a PAP performed at this visit. It comes back as negative, but is HPV positive. So what do you do now? And what is something you should be concerned about? All right. So there are 3 different screening options available for this type of patient. And, initially, a lot of times what we did was cytology. So actually just looking at the PAP results themselves. There's something called primary HPV testing, is where you're just looking at the actual HPV results. And then there's co-testing. And, what most people in this day and age do is co-testing. So you get both the cytology and the HPV testing combined, which, is very reasonable, especially in this situation. And then kind of using those results to move forward. The thing that's a little bit more concerning in this patient situation is that even though she's had normal cytology, she's been persistently HPV positive. And so that is concerning to have that persistence, knowing that virus has not been cleared. So one of the things to really hit home is that, especially if you have negative cytology, it can be we call the great pretender. And there still is risk, even with negative cytology, especially if they're HPV positive, that they could be harboring or have an infection that you just can't see, and have abnormal cells that have not been captured by the cytology. So in general, we know that HPV testing is actually a much better predictor of kind of what's going on. And so that is why there is a lot of talk about going to primary HPV testing only. So looking specifically at cervical adenocarcinoma, so there are several different types of cervical cancer. There's squamous cell carcinoma, which tends to show up a lot more on PAP tests, but adenocarcinoma can frequently, come back with normal cytology. However, HPV is frequently detected up to 93% in these patients with adenocarcinoma. And so, if someone has an abnormal HPV test, but normal cytology, it is important, especially if it's persistent, to evaluate it further. So there are new ASCCP guidelines, and overall what these are looking for, it's primary HPV testing based on risk estimation. So really looking at their testing, what their previous testing was, what their age is, and kind of using all of that information to then come up with what the next steps should be. This really allows for new testing methods that are validated to really figure out what is their risk of having CIN3. So that means kind of that higher grade dysplasia that would need treatment to try and prevent progression to cervical cancer. And so in general, these ASCCP guidelines are our standards that we use. So this is a really brief outline of kind of what this new risk stratification occurs. And so over here on the left, we see, is the immediate CIN3 plus risk greater than or equal to 4%, meaning, based on the history and kind of the current results, do we think that they have a risk of CIN3 plus more than 4%? If that is yes, then we kind of look at, do we need to treat them right away? Do we need to take a biopsy? And if the answer is no, kind of look at more long-term, when should we have them follow up based on how low risk they are? So again, this is talking about if they have CIN3 plus, meaning is this a high grade dysplasia, almost cancer, or what is there a risk for, potentially having cancer above 4%, then they definitely need some sort of biopsy or evaluation. And then if they have CIN, the risk is less than 4% of having CIN3 plus positivity, then we can kind of have them follow up in 1 to 5 years depending on what their results are. And so this new guidelines, the app will kind of give you that information based on all the data and history that you put in for them. The one caveat here is that women who are less than 25 are a different ball of wax. Younger women tend to have a much better way of clearing the virus just because their immune systems are better. They also, most of these individuals hopefully have been vaccinated, although obviously we definitely have many that are not. And so one, always make sure you ask them about vaccination status. And then two, just remember they're more likely to regress. So we're not quite as aggressive in our treatments with these patients. I will say I still see patients that are less than 25 that end up getting cervical cancer. So if you're concerned that they have a lesion that's, cancerous, or something just seems, not right, then, I do always recommend performing a biopsy or further evaluation to make sure that we're not missing anything. So how do we improve rates of follow-up? This is something that's really important to me because so many patients, may come in and get screened, but if they don't follow up with abnormal results, then the screening doesn't matter. And so the most important thing is really when you are screening patients, you need to let them know, we will close the loop. If you don't hear from us, that doesn't mean that everything is fine, but we will let you know that either your results are normal or abnormal. And if they're abnormal, these are the types of next steps you may need and why that's important. If your results are abnormal, that could mean you have a precancer or cancer and you really need to get that worked up. The other thing is that obviously we manage a lot of patients who may be pregnant with abnormal testing results. And so, using their follow-up paperwork to make sure that they get the right scheduled evaluation after they deliver their baby. And then really recommending that they still get HPV vaccination even after they're treated. So in general, the main takeaways I really want to hit home today are one, that cervical cancer is the third most common gynecologic malignancy in the United States, but it's completely preventable. Not completely, it is largely preventable disease, that we have both a screening method and an HPV vaccination method for prevention. It's most frequently caused by HPVs, and the majority of people will be infected with HPV at some point in their life. And so, really making sure this affects both men and women. And so because of that, it's really important to hit home that everyone needs to be vaccinated. Again, cervical cancer is preventable. We have both the HPV vaccine, which both men and women can get, and then the pap test, which is our screening method so that we can figure out if they need, some sort of procedure to try and prevent the abnormal cells from turning into cancer. And then the biggest thing I hope you take away from this lecture is that your voice is very important. And so being in, whatever situation you are, raising awareness about HPV vaccination and getting screened and telling, men and women it's important to go and see their doctor, is so important. But really educating those around you to make sure they get vaccinated or that they're getting their pap test to make sure they're compliant, and just really following up with those results as well. Um, and then finally, so there is this Operation Wipeout is a huge part of this cervical cancer elimination in Alabama. And this is really kind of hitting the point home. There's 3 steps. We can have the HPV vaccine, we've got screening, and then really following up and getting treatment if you do have an abnormal result. Again, my name is Teresa Boitano. I would love to answer any questions that you may have. Feel free to email me at my email listed here, or get in touch with me if you have questions, concerns, or a patient that you would like to talk about. And I appreciate your time and for listening today. Thank you so much.